Okay, these are the mobilizations for the elbow. We're going to start with improving elbow flexion. So when the elbow flexes, the radial head moves volar, the ulna gets distracted in end range flexion, and the radius and ulna move medially on the humerus. Okay, so whenever you mobilize the radial head, the proximal radius, you want the hand here, the elbow bent slightly, about 70 degrees, so it looks like the hand is in the pocket, and then you stabilize the humerus, grab the radial head, and gently push it volar. This is to improve flexion. Okay, so 6 to 10 repetitions like that. Then you move the elbow into its end range flexion. Put your mobilizing hand on the ulnar side, and now you're going to distract the ulna. Make sure your mobilizing hand is perpendicular to the forearm, and you are going to do a distraction. I'm pulling this way. Okay, do a distraction here. This is distracting the ulna in flexion. And now we want to glide the radius and ulna medially. So stand inside of the forearm, elbow bent slightly, at least 20 degrees through this mobilization. This hand glides the radius and ulna medially. This is stabilizing. My left hand stabilizing. My right hand's doing the mobilization. And that's the mobs for flexion. Now to improve extension, we're going to do all the opposites. Hand here, we're going to glide the radial head posterior. Okay. And then we're going to distract the ulna in their end range extension. So if this is as far as they can extend, we want to push the ulna perpendicularly this way. I can get down here and pull, or I could be up here and push. I'm on the wrong side of the elbow here, but I don't want to block your view. So I'm just basically using this hand to push the ulna posteriorly, perpendicular to the arm. So wherever this elbow is in end range extension, that's where you want to apply the mobilization. And then the radius and ulna are going to move laterally. So I'm going to move to the other side of the arm, elbow bent 90 degrees, and I'm pushing the radius and ulna laterally. And that is the mobilizations for elbow extension. Now we're going to do pronation. Pronation and supination are easy. We're going to glide the distal radius in the direction that it normally moves. So in pronation, it moves volar. In supination, it moves dorsal. So I'm trying to get supination, get them towards the end range of their supination, stabilize the ulna with this kind of grip here, and then I stabilize the radius and I do a dorsal glide. This is to improve supination. Then I would stretch into supination. To improve pronation, I do a volar glide. Just like that. Those are the mobilizations for the elbow. All right, this is the muscle engine technique to correct the position of the radial head. So we're going to do the posteriorly subluxed radial head first. Actually, I should show you how you assess it, right? So you assess it with the elbows bent 90 degrees and relax your arms here. And here with my index finger, I can feel the radial head. If this is her involved side, I want to compare it to the uninvolved side to determine if it is more prominent or less prominent. If it's more prominent, it's posteriorly displaced. If it's less prominent, it's anteriorly displaced. Okay? Either displacement can cause symptoms that are similar to tennis elbow or lateral condylitis. So let's say it's posteriorly displaced. It's the most common one. You're going to grab her hand. You want to supinate to the movement barrier. It's right here, so I feel breath and movement here. And then the patient will pronate. You resist that isometric pronation while you push the radial head anterior. So 1, 2, 3, 4, 5, relax. Take up the slack in supination. Then 1, 2, 3, 4, 5, relax. Take up the slack in supination and push again. 1, 2, 3, 4, 5. So I always like to say the patient and the therapist push in the direction of the correction. If it's stuck posteriorly, I want to push volar, and I want the patient to push in the volar direction as well. So if I'm trying to correct an anteriorly displaced radial head, I want to pull it posterior. I'm going to pronate till I feel movement here, and then she's going to supinate. Go ahead. When she isometrically supinates, I will pull 1, 2, 3, 4, 5. Relax. I'll pronate a little more to the movement barrier, and then 1, 2, 3, 4, 5, relax. And I'll pronate again, and one more time, open up. 1, 2, 3, 4, 5, relax. That's correction for an anteriorly displaced radial head. These are counter strain positions. So to remind you, we're going to be hyper shortening the tissues we are counter straining, and you have to palpate a tender point. So in the case of a tender point on the common extensor tendon, right here off the lateral epicondyle, that's where the tender point is. It could be the wrist extensors, ECRB, ECRL, or ECU, and those are shortened with elbow flexion, forearm supination, and wrist extension. Like that should take that tender point away. If it's extensor digitorum, same position with the exception of adding finger extensors. Okay, if it's the supinator, you simply supinate. Those are all the ones you will need to know for a tender point on the lateral side. Now for tender points on the medial side, this is the flexors. Elbow flexed, forearm pronated, wrist flexion. This is for flexor carpi radialis and flexor carpi ulnaris. If you're going to do flexor digitorum or superficialis, you just add finger flexion, monitoring the tender point on the medial elbow here. And then if it's the pronator, you simply pronate. And those are the counter strain positions on the medial elbow. Okay, in the case of pronator teres, it's counter strain this way, and you're monitoring the tender point on the medial epicondyle or the common flexor tendon here. Okay, in the case of pronator teres, pronator quadratus, the tender point would be down here in the distal wrist. You would still pronate. The difference is you're monitoring the tender point here on the dorsal forearm.